Clinical Guidelines for Treatment of Mental Health Post-Traumatic Stress. Please note that there are broad categories of signs and symptoms when experiencing post-traumatic stress, and symptoms or signs can vary from person to person. Let's view some of the symptoms or signs to look for. Directly experiencing the traumatic events, or witnessing in person the events as it occurred to others, or learning that the traumatic events occurred to a close family member or close friend. Experiencing repeated or extreme exposure to aversive details of the traumatic events, for example, first responders collecting human remains, or police officers repeatedly exposing details of child abuse. Recurrent, involuntary, and intrusive distressing memories of the traumatic event. Dissociative reactions, for example, flashbacks, in which the individual feels or acts as if the traumatic events were recurring. Such reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness of present surroundings. Recurrent distressing and upsetting dreams, in which the content and/or affect of the dream are related to the traumatic events. Intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic events, or marked physiological reactions to internal or external cues that symbolize or resemble an aspect of the traumatic events. Avoidance of, or efforts to avoid distressing memories, thoughts, or feelings about or closely associated with the traumatic events, or avoidance of, or efforts to avoid external reminders, people, places, conversations, activities, objects, situations that arouse distressing memories, thoughts, or feelings about, or closely associated with the traumatic events. Negative changes in thinking and mood, or about self or other people. Inability to experience positive emotions and feeling emotionally numb or feelings of detachment or estrangement from others. Markedly diminished interest or participation in significant activities. Persistent and exaggerated negative beliefs of hopelessness and low expectations about oneself, others, or the world. Inability to remember an important aspect of the traumatic events, typically due to dissociative amnesia, and not to other factors such as head injury, alcohol, or drugs. Difficulty maintaining close relationships. Changes in emotional reactions. Irritable behavior and angry outbursts, with little or no provocation, typically expressed as verbal or physical aggression, toward people or objects. Always being on guard for danger. Persistent negative emotional state, for example, fear, horror, anger, guilt, or shame. Reckless or self-destructive behavior, such as drinking too much or driving too fast. Problems with concentration, or sleep disturbance, for example, difficulty falling or staying asleep, or restless sleep. Hypervigilance, or exaggerated startle, or easily startled or frightened. The DSM-5 code and ICD-9-CM code recommended diagnosis for individuals post-traumatic stress is 309.81, F43.10, post-traumatic stress disorder. Now let's review 10 other disorders with similar symptoms, also known as differential diagnosis. 1. Adjustment disorders. In adjustment disorders, the stressor can be of any severity or type. The diagnosis of an adjustment disorder is used when the response to a stressor does not meet all other PTSD criteria or criteria for another mental disorder. An adjustment disorder is also diagnosed when the symptom pattern of PTSD occurs in response to a stressor that does not meet PTSD criteria. 2. Other post-traumatic disorders and conditions. Not all psychopathology that occurs in individuals exposed to an extreme stressor should necessarily be attributed to PTSD. The diagnosis requires that trauma exposure precede the onset or exacerbation of pertinent symptoms. Moreover, if the symptom response pattern to the extreme stressor meets criteria for another mental disorder, these diagnoses should be given instead of, or in addition to, PTSD. Other diagnoses and conditions are excluded if they are better explained by PTSD, for example, symptoms of panic disorder that occur only after exposure to traumatic reminders. If severe, symptom response patterns to the extreme stressor may warrant a separate diagnosis, for example, dissociative amnesia. 3. Acute distress disorder. Acute stress disorder is distinguished from PTSD because the symptom pattern in acute stress disorder is restricted to a duration of 3 days to 1 month following exposure to the traumatic event. 4. Anxiety disorders and obsessive-compulsive disorder. In OCD, there are recurrent intrusive thoughts, but these meet the definition of an obsession. In addition, the intrusive thoughts are not related to an experienced traumatic event, compulsions are usually present, and other symptoms of PTSD or acute stress disorder are typically absent. Neither the arousal and dissociative symptoms of panic disorder, nor the avoidance, irritability, and anxiety of generalized anxiety disorder are associated with a specific traumatic event. The symptoms of separation anxiety disorder are clearly related to separation from home or family, rather than to a traumatic event. 5. Major depressive disorder. Major depression may or may not be preceded by a traumatic event, and should be diagnosed if other PTSD symptoms are absent. 6. Personality disorders. Interpersonal difficulties that had their onset, or were greatly exacerbated, after exposure to a traumatic event may be an indication of PTSD, rather than with a personality disorder. Such difficulties would be expected independently of any traumatic exposure. 7. Dissociative disorders. Dissociative amnesia, dissociative identity disorder, and a personalization derealization disorder may or may not be preceded by exposure to a traumatic event, or may not have co-occurring PTSD symptoms. When full PTSD criteria are also met, however, the PTSD with dissociative symptoms subtypes should be considered. 8. Conversion disorder, also referred as functional neurological symptom disorder. The presence of new onset of somatic symptoms within the context of post-traumatic distress might be an indication of PTSD rather than conversion disorder. 9. Psychotic disorders. Flashbacks in PTSD must be distinguished from illusions, hallucinations, and other perceptual disturbances that may occur in schizophrenia, brief psychotic disorder, and other psychotic disorders, depressive and bipolar disorders with psychotic features, delirium, substance/medication-induced disorders, and psychotic disorders due to another medical condition. 10. Traumatic brain injury. When a brain injury occurs in the context of a traumatic event, for example, traumatic accident, bomb blast, acceleration/deceleration trauma, symptoms of PTSD may appear. An event causing head trauma may also constitute a psychological traumatic event, and traumatic brain injury, TBI-related neurocognitive symptoms are not mutually exclusive and may occur concurrently. Symptoms previously termed postconcussive, for example, headaches, dizziness, sensitivity to light or sound, irritability, concentration deficits, can occur in brain-injured and non-brain injured populations, including individuals with PTSD. The DSM-5 diagnostic criteria for post-traumatic stress is: A. Exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. 1. Directly experiencing the traumatic events. 2. Witnessing, in person, the events as it occurred to others. 3. Learning that the traumatic events occurred to a close family member or close friend. In cases of actual or threatened death of a family member or friend, the events must have been violent or accidental. 4. Experiencing repeated or extreme exposure to aversive details of the traumatic events, for example, first responders collecting human remains, police officers repeatedly exposed to details of child abuse. B. Presence of one, or more, of previously reviewed intrusion symptoms associated with the traumatic events, beginning after the traumatic events occurred. C. Persistent avoidance of stimuli associated with the traumatic events, beginning after the traumatic events occurred, as evidenced by one or more of the intrusion symptoms listed. D. Negative alterations in cognitions and mood associated with the traumatic events, beginning or worsening after the traumatic events occurred, as evidenced by two or more of the intrusion symptoms listed or reviewed. F. Duration of the disturbance is more than 1 month. G. The disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. H. The disturbance is not attributable to the physiological effects of a substance, for example, medication, alcohol, or another medical condition. Important areas to consider when setting a treatment plan for individuals with post-traumatic stress disorder. 1. Lower the negative effect that the traumatic event has had and return to pre-trauma level of functioning. 2. Recall the traumatic event without becoming overtaken with negative emotions, and increase awareness and understanding of PTSD development and the rationale for treatment. 3. Establish effective coping skills to carry out normal responsibilities and constructive relationships. 4. Stop destructive behaviors that serve to maintain escape and denial and implement behaviors that promote healing, acceptance of the past events, and responsible functioning. 5. Increase communication skills and teach how to deal with daily stressors and increase levels of tolerance, comprehension, calmness, and the physical ability to release stress by pursuing stress-releasing activities. 6. Explore and assess the history, symptoms, and nature of the PTSD, and refer for complete psychological, medical testing to assess for symptoms of post-traumatic stress disorder. 7. Identify, verbalize the symptoms of depression, including any suicidal ideation, and explore information or history of chemical dependence and biopsychosocial history. 8. Identify and implement coping and calming strategies to manage and challenge thoughts and situations related to trauma, and list negative self-talk that is associated with past trauma and current stimulus triggers for anxiety. 9. Express an awareness of poor anger control and implement anger control techniques and increase a hopeful and positive attitude regarding the future. 10. Implement and teach how to use a regular exercise regimen to learn to release stress and increase sleep without disturbing dreams of the trauma. Reach us at therapytools.us and don't forget to subscribe and share. Also, check how to organize and simplify a mental health treatment plan with the Adult or Child Treatment Planner apps for Windows or Apple operating systems. All proceeds go to charity.